Welcome to The Scope with Dr. K, where together we can reimagine GI care. Welcome to The Scope with Dr. K. I'm Dr. Kaczynski and would like to open the show reminding all of you that the goal of this series is to present you a broad scope of issues, mainly involving the field of gastroenterology. Although our main focus might be gastroenterology, in each episode, we also plan to bring you cutting-edge information outside of the GI field through a focused interview with an influential and interesting key opinion leader. Our guest today is a long friend of mine and colleague, Lili Brillstein, who is CEO of BCollaborative, a consulting firm focusing on value-based care. She's most commonly known, though, for her work at Horizon Blue Cross of New Jersey, where she led their value-based episode of care program. We are lucky and honored to have Lili today as our guest. Hello, Lili.
Hello, Larry. Thank you so much for having me.
Well, it's our honor. Lili, even though we're going to talk a lot today about value-based care, let's start by you giving the listeners a little introduction of yourself. Tell us about yourself and your career.
Sure. So my background is really in public health, and I started my career doing work around HIV/AIDS discrimination and domestic violence. And honestly, never ever thought I'd wind up working for any insurance company. I spent really the first 9 years of my career at a major hospital system in New York, after which I was recruited to work for a New York-based regional health plan, where I was responsible for contracting for facility and ancillary services. I spent a lot of my time there sort of trying to choreograph a dance between the business teams and the clinical teams, because when I got there, I saw really the business of each was being conducted without being informed at all by the work of the other. So in other words, contracts were being written by business folks who really did not have input from the clinical teams, and the clinical teams were talking to providers and others really without any information from the business teams. So that didn't really make a lot of sense to me, and coming from the public health space, I really kind of needed to make a little bit of sense of that. I was quite struck that as contracts were being written and negotiated every day, there was never ever a discussion about the patient. The patient never came up in any contract discussion about care of those patients. And so I would say my career as a collaborator really started there, right in fee-for-service. I would spend time talking with the docs, and I would talk with my leadership and my team at the health plan. We would meet and listen to each other, and we would contemplate together what made the most sense in terms of caring for our patients and making sure we use the most effective use of limited resources. I really worked with the clinical teams to build presentations that we could deliver together. And really it was, this was back in the early 1990s, and it was really the first time there was really any collaboration happening between providers and managed care.
This still exists today. In our work at Sonar, we are oftentimes dealing with either the medical side or the business side. Seldom do we speak with both sides together. And I can imagine how difficult it is on the inside of an organization as large as a health plan to make sure that everything that's being done on one side coordinates with the other side. Lili, how long did you work at the health plan?
So I was at HIP Health Plan in New York for about 9 years. And then I worked at United for a few years, for 4 years, and then I was at Horizon for about just under 7. So really about 20 years I spent on the health plan side. And I would say really in every one of those roles, I was always working with providers and working to sort of bring a different face of the managed care organization, one that was more of a partner, because that really is the spirit that I come from and the spirit that I bring to the work. And I just don't understand doing it any other way.
You mentioned that you spent time at both United as well as Horizon. Are there differences between them? Anything you can share with us?
The differences in a national plan like United versus a regional plan are pretty significant. And in many ways, it's a bit easier to lift off certain programs with a regional plan because you're typically dealing with one state, and the markets, while they may be varied within the state, it's not quite as variant as it might be across the country. And really creating models that work across the country with a gigantic national plan, which also means the matrix is so much bigger, and so there's so much more coordination that has to occur in the house, is really a really important difference. The things that are the same, though, are all of the health plans in this country, really, their systems sit on a fee-for-service chassis, and they're set up to think about and pay for care in terms of increments and units of care versus what we think of in value-based medicine or value-based care models, where we're really talking about the suite of services related to a particular diagnosis or healthcare event or condition. And so making the shift on the system side, even alone, to be able to contemplate these models and pay for them is kind of a gargantuan task, not at all easy. And that is the same, whether it's a regional plan or a national plan, in my experience.
Again, the parallel to clinical practice on the provider side is strong here. We live in a fee-for-service world as well. We perform a colonoscopy, we get paid for a colonoscopy. We have an office visit, we get paid for that office visit. The move to value-based care has to force everybody to think in a different mindset so that you're thinking about what's happening to that patient over the long term, what's happening to a population of patients over the long term. I know we're going to talk about this a little bit more later, but it's interesting to see that the same difficulties are being experienced on the payer side as are being experienced on the provider side.
Yeah, absolutely. And, as I sort of work around the country, one of my goals and one of the things I think that helps to make these models successful, and that really they can't be successful without it, is a respectful partnership. And that's not something we've had a lot of in this industry over time. And so I talk to payers about making sure, I talk to all the parties about, the goal of sort of leveraging the expertise of each of the partners and respecting the fact that the different partners and parties bring a different set of expertise to the table. And so with the providers, certainly their expertise is in the clinical care of their patients. And with payers, they have the longitudinal view and data of what's been happening to those patients outside of the physician's office that can enable them and help them identify where there are variations in care and cost of care. But I tell them both, when I talk to payers, I suggest that it's really important to listen to the providers and not go in with an idea of what success will look like before we talk to the providers to see clinically what does success look like? How do we know we're successful here? And I talk to the providers about making sure they understand that not everything that might make really great clinical sense is easily administered or administrable by the plans. And so as they contemplate these models, that they need to be able to listen to one another and figure out a model that's clinically meaningful and also can be administered by the plans. Both of those things really have to be there and be in place for things to be successful. And I find that shift in thinking is actually tough for a lot of players because we're so accustomed to contracting in healthcare with our dukes up and everybody's sort of fighting. And this requires that everybody takes their fist down, does not go in and start with no, and consider what actually is meaningful and what can they actually, sort of lift off.
It is so refreshing to hear you explain your thought process here. For the majority of my career, I would look upon the payer as the evil empire because the answers were forced upon us in the word we heard usually was no.
Right.
And what's interesting is to see what has transitioned over the last few years. For most of my career, the hospital executives were closer to us. We saw them on a regular basis. We went on golf outings with them. We had social events with them. And yet we almost never had any interaction with the payer, any of the executives from the payer, unless we were at contract time. And then it was an adversarial experience. Today, things have flipped. On the hospital side, hospital systems have gotten so large that the people who are making the decisions in the hospital systems are not close to the providers anymore. A lot of the providers now are employees of those hospital systems. And on the other side, I have been pleased, actually surprised by the relationships I've been able to build on the payer side. And one of the reasons you and I have known each other for so long is that we built our relationship with each other long before we knew each other as colleagues in a different way. It was because you were on the payer side, I was on the provider side. We would speak at conferences together. And I'll never forget the first time I heard you speak. I thought, wow, I hope all the rest of the people at the payers are thinking the same way that Lili is. I'm still not sure that's the case, but let's go a little bit deeper into your time at Horizon, because one of the things you are known for in the GI community are your episodes of care.
So when I got there, which was in January of 2013, Horizon was just coming out of its very first pilot in the specialty care value-based models in the episodes of care. And it was a hip and knee replacement. There were 2 episodes, hip and knee replacement surgeries. And by the time I got there, the pilot had been going on for about 2 years. And the pilot proved that for those orthopedic procedures, if you focused on all of the care rendered to the patient related to the surgery, rather than just the increments of care, the overall outcomes and patient experiences were improved, and there was also a reduction in overall cost of care. And that was really about sort of sharing data so that the orthopedic surgeons who were conducting these episodes, if you will, could see what was happening to their patients in a manner that they couldn't before, because data wasn't being shared and they were only really focused on the care they rendered. Once they were in these value-based models, it became important to understand where were the patients going before and after they left surgery, was the care optimized and was the use of resources optimized. And so all pillars of the triple aim, all the goals of the triple aim were being met successfully in the pilot. And so when I came in, I was asked to scale the program. And it was a wonderful opportunity, being coming from a public health background and having a little bit of a different spirit than I had really found in the managed care organizations. And it was an opportunity to sort of rethink and reorganize sort of what does it mean to be a partner in healthcare and to be a part of creating better outcomes and experiences, as opposed to just looking at units of care and increments of cost of care. So my goal was really to build a program that sort of tested the model in multiple scenarios, right? So not just in procedural episodes, which are pretty simple to start with. They're a place that a lot of plans will start because they're simple to define. They're discrete procedures. It's usually one and the patient is done. So, you can build, a model that sort of fits very neatly. You can trigger it with the surgery and look at a few days before or a few weeks after to capture all of the related services and follow-up activities and create some good measures. But I was really interested in testing the model in different kinds of episodes. So not just those that were procedural, but also in acute and chronic condition episodes that are a little bit more difficult to construct. And I was also really interested in looking at whether we could sort of stretch the model a little bit. What I mean by that is if you think about episodes of care, typically the model is extremely good at managing the care of patients who wind up in the episode. And it doesn't typically address whether the patient needed to be in the episode in the first place, right? Did the patient need the C-section? Did the patient need the knee surgery? And I was really interested in looking at, could we help address that as well? And in the state where I was working at the time in New Jersey, the state had the highest rate of C-section, for example, in the country, and by a lot. And so I wanted to be able to look at models that could address that. So we had a really, really good time. I had a great team, and we met with our partners, and we would invite them in to help us think about how to build these episodes. What was the criteria that made most sense? When would we start? When would we end? What were the services that should be covered? What are the variations in care and cost of care that are most important? And what data did they need? Did the clinical experts need to be able to create success here and sort of reduce that variation in care and cost of care, which is really what these models are about?
If you're just tuning in, you are listening to The Scope with Dr. K. Our guest today is Lili Brillstein, and we are discussing value-based care. So your pivot into GI made sense with an initial focus on colonoscopy.
That's right. So, I'm a big believer in starting in a place where everybody can figure out what to do and how to create success. I am not a huge believer in trying to skip the evolutionary nature of the models and assume that you can go from fee-for-service to very complicated risk-based models without the experience of sort of more fundamental episodes. And so using GI and starting with colonoscopy as one of our very early episodes after the pilot made really good sense because there are tons of them, and while there's not a huge amount of opportunity per episode, because the continuum of care is not that big, it's pretty well contained. The doc has control over most of it, and the opportunity was really around two specific things in colonoscopy, and that was the site of service and also the type of anesthesia used. And because the docs really could control most of those decisions, and the continuum really wasn't that gigantic, it was a relatively easy place to be able to start in GI. And honestly, I found the GI docs were great to work with. The AGA I found was extremely supportive also, which was very, very helpful. It's not the case in every specialty. And what happened as a result of that was our GI partners became quite engaged and learned with us, as we learned, how to create success in these models using a pretty simple episode in colonoscopy. And from there, we were able to build some much more complex episodes. And certainly the IBD episode, which included both Crohn's and ulcerative colitis, is a complicated episode. It's a chronic condition without a very neat beginning and end, has behavioral health components and a lot of other things that certainly impact patient outcomes and experiences and the cost of care. And it's really because of the partnerships we built, the trust we developed, and the mutual respect that really we shared with our partners that allowed us to come together in rooms to figure out, with no threats and no fists up, how to build models that had some real clinical impact, as well as creating financial efficiencies that didn't exist before.
Lili, you touched on a number of topics here, but one that strikes me is the difference in how the economic models can be crafted around something like a colonoscopy procedural bundle versus what type of economic models need to be crafted around an episode of care for a chronic illness. Our, our internal research that we performed with Healthcare Service Corporation has shown an enormous difference in the variability of cost between these two types of entities. Let me give you an example. We have developed a concept called a beta concept, and it's very similar to the type of financial concept that's used in financial portfolios for investments, where some stocks vary a large amount against an index, whereas others vary very little. And those that vary a lot are called high beta, and those that vary much less are called low beta. Well, we were able to create an index for GI illnesses, and then we plotted the variability in cost of all of the major GI conditions against that index. Colonoscopy varies very little against that index, whereas inflammatory bowel disease, Crohn's disease in particular, has an enormous variation. So it's a high per capita cost. It has high variability in that per capita cost. And it's a symptomatic illness that has very significant effects on the patient population that suffers from it. So the challenges here are significantly different. I can see where bundles can be created very efficiently for procedural services like colonoscopy, where it's much more difficult for the disease-driven conditions. So Lili, we are talking about the difference between procedural bundles and disease-based bundles. How do you manage the difference between these two?
You know, it's such a good question, Larry, and I get asked it a lot. And, you know, as people are beginning to understand episodes and bundles, there's still a lot of sort of head scratching around how can it possibly apply to chronic condition episodes. And so what I would say is when you think about, if you think about a procedural episode, you know, you typically have some criteria that you use to craft the model, right? So you think about what triggers the episode, meaning what event or procedure or diagnosis is it that qualifies somebody to be in the episode in the first place? And it's whatever it is, it is something that makes that individual clinically similar to other individuals who will be in the episode. And so, in other words, it may be they're having a knee replacement episode. And then you think about what is day one of the episode, meaning what's the first day that we're going to measure? And typically in a procedural episode, you'll look at some period of time before the episode, maybe, 2 weeks or 30 days, so that you can capture that sort of preoperative or prehab portion of the episode, if you will, the labs, radiology, et cetera. And then you want to figure out some portion after the procedure so that you can capture the post-acute care. Did the patient go home? Are they going to a SNF? Where did they have, or what kind of rehab are they having? What's the use of opioids? Is there a readmission? Is there infection, et cetera? And so you kind of identify criteria that gives you the time period and takes the snapshot so that you're looking at a patient with the same view, looking at all the patients with sort of the same view of where they are in the healthcare continuum. And again, in a procedural episode, it's pretty simple to do. In a chronic condition episode, they're not one and done. Often in a situation like Crohn's, for example, patients continue to have the diagnosis. They don't have a quote episode that begins and ends, but in order to look at outcomes and look at experience and look at cost of care, we sort of have to somehow artificially create an artificial set of boundaries that allows us to take a snapshot of patients so that they are in a somewhat similar space. And so as I build chronic condition episodes, I use the exact same design criteria. So that is, what triggers the episode? And again, it's a decision that would be made between the clinicians and the payer and whoever the other partners are. So in Crohn's, for example, is it the date of diagnosis? Is it the date of a first treatment? Is it an admission to the hospital? There really isn't a right or wrong. It depends on what the parties are trying to look for, what they're trying to look at. And then once you have identified what is it that qualifies a patient or an individual to be in the episode, you want to look at what's day one. What's the first day you're going to start to measure? Again, is it going to be the same as the trigger? Is it going to be the date of diagnosis? Is it going to be the first date of an infusion or some other treatment or an admission? And then how long will you keep that episode open? And this is where it's a little tricky, right? So in chronic condition episodes, again, there's not a natural end point as there is or might be in a procedural episode. And so you have to create some sort of artificial end point so that you have like measurement periods. And typically in a chronic condition episode, most of the episodes that I've seen and been involved in building typically are either 6-month or 1-year increments. So you look at the patient for 6 months or for 1 year based on all of the criteria that gets established, and then you assess the quality metrics that you've established, and you assess the financial thresholds that you've established as well. And then typically in chronic conditions, the patient will then, let's say the episode is 365 days, the 366th day becomes day one of their next episode, right? So they roll over into a second episode. The one more complicating thing about the chronic condition episodes is that sometimes, like in oncology, this happens. Year one of a patient's episode may be very, very different than years 2 and 3, right? Much of the care, the aggressive care may really happen in the first year. And so sometimes years 2 and 3 of a chronic condition episode have different sets of criteria. But generally they sort of continue to roll over.
Lili, you and I can probably speak for hours about the nuances of these episodes of care for chronic disease. And I'm going to lock you in right now to agree to come back another time so we can discuss things further. Can I hold you to that?
You can absolutely hold me to that.
All right. Well, thanks for joining us today, everybody. Until next time, this is Dr. K. Thanks for listening. I'm Dr. K. Tune in with me next time to reimagine the scope of GI care. If we build it, they will join.